change happen in the coding and reimbursement world so quickly. So hopefully in the next hour, I will make this clear to you. And if you have some knowledge of the telemedicine codes as they were defined prior to March 17th, I don't want to cause any confusion, so I'll just say simply put that information that you knew in a shoebox and put it on the shelf, because we're operating under some exceptions to the rules right now. They're very, very different for the time being. And then hopefully when this all goes away and we adopt telemedicine in a different, more traditional way, you can become more familiar with those regular rules regarding telemedicine coding. I do have a lot of slides to go over with you, and some at the end we won't. Those are going to be, saved for future reference when you start to continue the regular telemedicine codes. But for today, we're going to talk about the present crisis and what you can do to bill for remote visits. Because of the waivers under Section 1135, there has been some relaxation of the rules. You can actually bill your evaluation management service codes for patients who don't come into your office. So that's the great news, and I want everybody in the next hour to be comfortable with how to proceed with that and not just get the reimbursement at the level of a telephone call or the portal communications. We'll talk about some modifiers and diagnosis to support your claims as well. We will give you detailed handouts. I've got lists of the CPT codes. I've got some question and answer, reimbursement amounts, the telemedicine grid. So if you have questions, please hold them from the queue until the end, because it's going to most likely be covered. And then if you need something clarified, I'd be happy to do it at the end of the presentation. Telemedicine is the practice of medicine using technology to deliver care at a distance. It must be patient initiated, and that is true at this time. You can't call patients who are a no-show and then take care of them and bill them without their knowledge. So the patient does need to make the request for the telemedicine service to be rendered to them, and you can bill it as long as you're documenting and performing the key components of an evaluation management visit, and we'll go over that as we break it down. Medicare does have some modifier requirements generally. The GT modifier is one. The patient must be in a HPSA shortage area, that's another. But now, for the time being, since this emergency has occurred, these Medicare requirements are being waived. The telemedicine codes are now going to include 99201 to 99205, 99211 to 99215, and the consult codes 99241 to 99245 for payers that recognize those codes. Depending on the payer and depending on the state, you will have different reimbursement and billing guidelines. Some states don't recognize certain types of providers, for example, naturopathic physicians or chiropractors. Other state Medicaid programs and Medicare programs do. So know what your state licensure and scope of practice allows you to bill for. Check with your malpractice carrier if you're going to be changing the scope of your practice or in any way. If you have legal questions, ask your legal counsel. I'm not a lawyer, I can give you coding information, but not legal advice. There are a lot of websites that have a lot of documentation. Yesterday, the AMA came out with a very easy to follow grid, and I have a link to that as well. The normal telemedicine modifiers on modifier 95 we see is still being requested quite a bit from non-Medicare payers, meaning Blue Cross, United, all of the different commercial plans. And what that means, it's a real-time interaction between a physician and a patient who's located at a distant site. So you may be using modifier 95 for your visits at this time. The big change occurred on March 17th when CMS issued guidance on Health and Human Services Secretary Azar's waiver authority that broadens access to Medicare telehealth services. The important thing to note is that you may backdate and go back and capture services that you may have rendered as long as they fit the criteria and are documented for dates of service on or after March 6, 2020. And these temporary rules will continue for the duration of the COVID-19 public health emergency until HHS declares that there is no longer a public health emergency. We're going to be under these new rules, so we'll have to be careful and watch for that date to occur sooner than later, I hope. CMS will allow qualified healthcare providers to care for patients remotely, so qualified healthcare professionals we'll talk about in a minute, but it doesn't mean the nurse in the office who's making a phone call. It means somebody who's a billing provider. So other payers will likely change their policies. I've been doing these webinars for a week now, and I've had a lot of folks forward to me payer policies that they've received from major carriers, and they are, for the most part, in line with CMS. The geographic restrictions that are usually under the telehealth guidelines have been waived, so as of March 17th, patients can receive telehealth services in non-rural areas. There's no restriction anymore as far as being in a healthcare shortage area. The originating site traditionally for telemedicine is in a physician's office using a telemedicine platform to connect with another physician at a distant site or in an authorized healthcare facility. No longer is that the rule for now. Patients can be anywhere, particularly in their homes, for the setting of care for this remote visit. The type of communication device is also going to be relaxed, but there must be audio and video capabilities. So during the COVID-19 nationwide public health emergency, it is okay for your providers to communicate with the patients as long as that's a non-public facing remote communication product. So that includes smartphones, and smartphones was specified by HHS. As if it's not a smartphone and it's just a telephone call, there's no video, then you can use the telephone code calls or the virtual check-in calls that we'll discuss in a moment. Real-time communication means that it is interactive and live, audio and video, between the patient and the provider. So FaceTime on an iPhone is an example of real-time communication. Under this HHS notice, however, public-facing services like streaming services are not allowed, and they specifically prohibited Facebook Live, Twitch, TikTok, and similar video communications because they are not considered to be secure. Other HIPAA considerations during the COVID-19 emergency is that you don't have to comply with all the HIPAA rules, asking for patients to sign an authorization form to communicate with them remotely. Those things will not be investigated, even though they're not fully compliant with the HHS rules and the HIPAA rules. And likewise, the technologies, the smartphones are generally not allowed under telemedicine. You have to use a secure telemedicine platform, but right now they are allowing smartphones, even though they don't fully comply. This relaxed regulation comes from the Office of Civil Rights, and at the end of my Q&A sheet that I'm going to be sending to you, there are links to all of these legislation sources so you can review them and keep them on file in your office. But the OSCR did come out and say that they will enforce discretion on and not impose any penalties for non-compliance with the regulatory compliance requirements under HIPAA, as long as the provider is taking care of the patients in good faith, providing telemedicine during this crisis. The notification was effective immediately, and that was published on March 17th. Now, you might work for a larger healthcare system that has more stringent privacy rules and they won't allow you to use the telephones, for example, for the provision of the remote visits at this time. And if that is the case, you might want to use some kind of a HIPAA compliant vendor who will sign a HIPAA business associate agreement with you. Some examples that HHS has given us are Skype for Business, UpDocs, VC, Zoom for Healthcare, Doxy.me, Google G Suites, Google Hangouts, Google Meeting, among others. The type of providers who are eligible to perform evaluation management services remotely and bill them as a face-to-face visit include doctors, nurse practitioners, physician assistants, nurse midwives, certified nurse anesthetists, clinical psychologists, licensed clinical social workers, registered dietitians, and nutrition professionals. It may vary from state to state who else is considered to be a licensed provider. Check your state regulations on top of this guidance. And what codes can be billed, we will also give you a PDF of the 101 codes that are designated as eligible for telehealth payment, and they include office and outpatient visits, subsequent hospital and subsequent nursing facility care visits, psychotherapy, health and behavioral assessment and interventions, end-stage renal disease. I have gotten questions about preventive medicine visits, so I'll point out that they're not covered for any age using the 99281 through 99209 codes. But the annual wellness visit for Medicare, initial and subsequent, is actually on the list of covered services because there's not much in terms of a physical exam, and you could certainly accomplish the questionnaire with the patient remotely. Under this new legislation, the temporary legislation, Medicare telehealth services are generally going to be billed as if the service had been furnished in person. The thing that will tell Medicare on the claim that it was not actually in person is you're going to change your place of service code from 11 to code 02 for telehealth. And that is specifically for the codes that describe face-to-face services that are done remotely. So I'll also be talking about some other codes that are for telephone or internet communications, and you don't have to change the place of service for those, just the office codes. The amount of reimbursement, and this is a very, very important point because we know that your schedules are empty, patients are not showing up, or they're canceling their appointments because they need to stay at home. The whole purpose of this is to keep the patients safe in their homes and not close the offices by reducing the reimbursement too much. So hopefully this will help you a lot because Medicare will pay the same amount for the telehealth services according to the physician fee schedule as if the patient was seen in person. If there is a CPT code that has two different rates for facility versus non-facility, Medicare is going to look at the 02 place of service code and pay you the facility payment rate for that. Now, when the patient comes into the office, you generally collect a copay because these E&M services have copays attached to them. But with the remote visits, the patient's not going to be presenting in the office and checking in. It could present some challenges for you operationally to collect that copay. And usually it's a compliance issue if you waive copays and cost sharing, but HHS is providing flexibility for providers to reduce or waive the cost sharing for the telehealth visits. So that's copays, high deductibles, co-insurance. The use of telehealth doesn't change that the patient will have an out-of-pocket cost when their claim is paid to you, but you are given the flexibility if you're not able to collect it because the patient is not there. But let me clarify, it's not required to waive the copay. If you want to bill the copay and collect it the next time they come into your office, or send them a bill, or collect it remotely with a credit card, that certainly is up to you. The rules also do not enforce the established relationship requirement that a provider see a patient within the last 3 years. Normally with telemedicine codes, they're for established patients only. You can use the 99201 to 99205 if it is a new patient. It's going to be a little challenging when we get to the part of the presentation when we talk about documenting your SOAP note, because you have to have all three of the elements, history, exam, and medical decision making, in order to bill a new patient code. But the alternative is to document time to support the level of service. So it's really important. And I would recommend that your notes for the time being for these remote visits start with a statement that it was patient initiated, that it was remote, and signify the technology that you're using, that it was audio and video using Zoom or Skype or FaceTime, for example. And then at the bottom of your note, summarize and document the amount of time. I think that will be very good in terms of supporting your billing and E&M service and not having it questioned as merely a phone call. For things that are less than an E&M service, there were some codes available to us before this all came up. And we'll talk about the virtual check-ins, which are short patient-initiated communications with a healthcare practitioner. Those are usually either emails or through a patient portal. The expanded rules also will allow telephone for the code G2012 for virtual check-ins. The purpose of a virtual check-in is to decide whether or not an office visit or other service is needed, and a remote evaluation is submitted by this established patient. Medicare Part B pays conditions for e-visits as well, and e-visits are online medical services, non-face-to-face, from the physician or other qualified healthcare provider, including all the communication, and those are billed over a week period. period of time. The G2012 for the virtual check-in, the national average for Medicare pays about $14.80 for that. They are brief, 5 to 10 minutes, and they should not be in follow-up to an office visit that occurred within the previous week, nor should they lead to an office visit or procedure within the next 24 hours or soonest available appointment. Otherwise, they would be considered global to those billable visits. Clinicians who may not independently bill for evaluation management services, some of your ancillary providers in your office could include physical therapists, occupational therapists, speech language pathologists, clinical psychologists. They can also provide the e-visits and bill the codes G2061, G2062, and G2063. And those are for cumulative time spent over the course of a week, total time for 7 days, and the 3 codes are based on total time increments documented of 5 to 10 minutes, 11 to 20 minutes, and 21 minutes or more. And I jotted down the Medicare national average allowable for those. The codes for the online digital evaluation and management will now include telephone as well. And those are also for a period of up to 7 days cumulative time. So those can be by physicians or other qualified healthcare providers. And they are cumulative service time within a 7-day time frame to evaluate, assess, and manage the patient. It could include ordering tests, prescription generation, separate digital inquiry for new and unrelated problems, subsequent communication that is digitally supported, such as email, online, or telephone, and digital services initiated by the patient. So how is the virtual check-in different than the e-visits? The virtual check-ins pays professionals for brief communications that might mitigate the need for an in-person visit, whereas the visit furnished via Medicare telehealth is treated the same as an in-person visit with the 99211 to 99215 with the service code 02. The e-visit is when the beneficiary communicates with their doctors through an online portal. We also have the physician telephone service codes. These codes are not paid by Medicare, but other carriers might pay for these if they're not paying for the G2012. And those are 99441, 99442, and 443 for 5 to 10 minutes, 11 to 20 minutes, and 21 to 30 minutes. And that's not cumulative. That's for that specific telephone encounter. And again, it's not going to be paid if it's bumping up against a visit that occurred in the previous week or that will occur within the next 24 hours as soon as available appointment. Non-physician telephone service codes have the same time thresholds and the same rules. So these could be for nurse practitioners. When nurse practitioners would use the qualifying physician, nurse, physical therapy, occupational therapy, the same non-physician health professionals we mentioned on the earlier slides. So these also have to have the time documented, and this is for one particular call, not calls over a period of a week. So to put these all together for you, I made up this little chart that shows you what we just discussed in terms of the types of services, the virtual check-ins, the e-visits, and the telephone only, the CPT codes that you use to report them, and what the service is. And be careful to check back in the previous slides a little more detail to make sure that you're using the codes that are appropriate for the type of provider. For example, in the telephone only box in the bottom row, I have the 3 codes on the top for the physician and then the 3 codes on the bottom for the non-physician. So keep them separate in terms of who the provider is, and you should be all set. So if it's not one of the previous services we just talked about with telephone and portal, if it's the audio and video and the patient is actually going to have a visit remotely, we need to document an office visit. We need to have a SOAP note. So the history exam and medical decision-making components are not waived, even though the patient is not there in front of you. The documentation requirements do need to have a history, exam, and medical decision-making to support the level of service. Don't open a template for a telephone note, open the template for an office encounter. You're merely changing the place of service on this to O2 and making a statement that it was accomplished through the use of audio and video technology on both the patient and the provider side. The HPI should then explain what this visit is about, how the patient has a complaint somewhere on the body, how severe it is, or the characteristics, what's the quality, the timing, how frequently it happens or patterns are occurring, and the duration, how long it's been going on, modifying factors and context, what makes it better or worse, what brought the problem on, associated signs and symptoms the patient has when they experience the chief complaint. So it's just a good complete sentence of what this is pertaining to. Brief HPI will support a 99212 or 99213. Extended HPI is 4 elements that will support a 99214 and 99215. Then we go on to the review of systems, which can be a narrative right on the same paragraph as the HPI. Patient denies nausea, vomiting, and dizziness are typical statements that we see, and we give credit for GI and neuro in addition to the elements of the HPI. It might be something like patient has a headache that is so bad it makes her nauseous, and then you have 2 systems right there as well, and they're very intentional towards the reason for the visit. There are 4 levels of review of systems. None is required for 99212. 1 is required for 99213. A second system is required for 99214. So to get a detailed history, I just illustrated that, headache and nausea type of thing. It's pretty easy to do that. But for your new patients, you do have to have a complete 10-system review of systems in order to have a 99204 or 99205. So you do want to refer to the checklist to make sure that you have enough history and exam to go along with your medical decision-making for those higher levels of new patient visits. Past feeling and social history is also considered. So if there's a discussion of the patient's illnesses, allergies, medications, that would consider past history. Family history should be relevant to the reason for the chief complaint, and social history or any lifestyle factors that are affecting the patient's health status, and particularly today, exposure to another patient with COVID-19 would be very important, and that would be considered social history. Even if it's a family member who has COVID-19 that they're exposed to, that's not something that is hereditary, so it would be a social history factor. To sum it all up, with history, you draw a line across the row where all elements are met or exceeded for the level of history. So starting with problem focused, we have level 2, 3, 4, and 5. You do have to have some physical exam if it's possible, because the patient is in front of you on video. Only document observations that were made during the remote visit. If a patient can report to you any numbers such as height, weight, blood pressure because they have a simple blood pressure cuff at home or a pulse oximetry, then you can count that towards vital signs. Or constitutional can be a statement of the patient's general appearance. You can see their eyes. You might be able to tell them to take a deep breath and hear them breathing. You might be able to look at their skin. You might be able to conduct some elements of psychiatric exam through interviewing of the patient. So only document the physical exam elements that you can personally observe during this remote audio and video visit. And then the guidelines here give us the limited exam or extended exam, for example, between a 99213 and a 99214. The most important part of the documentation is going to be supporting medical necessity. The assessment and the number of diagnoses that were discussed during this remote visit, as well as the treatment plan and the level of risk to the patient. And the way that this is calculated is we have a number of points for problems and data, and we have a table of risks, so I'll go right on and go through those. This is probably familiar to everyone on the call. It's the Marshfield Clinic guidelines that we're still working on under for the rest of 2020 until we get into the 2021 E&M changes. But for today, you're going to be looking at 1 point for limited or minor problems, 1 point for stable problems, 2 points if an established problem is worsening, 3 points for new problems with no further workup, and 4 points for a new problem with tests that are ordered. Your data points for medical decision making are assigned by category: labs, radiology, and medicine tests such as EMGs, EKGs, pulmonary tests, allergy tests. All get 1 point per category, not per test. If you discuss the test results with the physician who performed the test, that is a point. And if you decide to obtain old records, that's also a point. When you summarize old records or personally view an image tracing or specimen and document what the findings were, those are 2 points each for data points. And that can be important in some specialties to add up to the complexity of medical decision making. The last element of MDM is the table of risk, and this is an abbreviated table that we use because the middle table, a middle column, would just make this too small for you to read, and we seldom find that it's useful. So the minimal problems, 99212 is a self-limited or minor problem, something that's going to be, resolving on its own with rest, gargles, hydration. Low risk problems supported 99213, and that can be 2 or more self-limited or minor problems. 1 stable chronic illness such as well-controlled hypertension, stable diabetes, cataracts, BPH, or an uncomplicated illness or injury. A lot of the urgent care type of things fall into this category, such as urinary tract infections and allergies and sprains and sinus infections and viral illnesses that are run-of-the-mill, such as gastritis and those sort of things. Over-the-counter medications, minor surgery with no identified risk, physical therapy, fluids are usually the remedies for things that are low risk that would match a 99213. Moderate presenting problems would be a chronic illness that's worsening, progressing, or the patient's complaining of new side effects from their treatment. 2 or more stable chronic illnesses, an undiagnosed new problem with further workup, an acute illness with systemic symptoms. So this is more of a CKD and pneumonia type of things, or acute complicated injuries. The remedies here would be surgery that is scheduled, prescription drug management, such as writing a new prescription, renewing recently prescribed drugs, adjusting dosages, or discontinuing medications. And then high risk for 99215 would be a chronic illness with severe exacerbation, progressive, or side effects of treatment, or an acute or chronic illness that is posing a threat to life and organ function. It could be neurologic, stroke, seizures, TIAs, much more emergent in this category where you'd be advising the patient to go to the hospital, but still this remote evaluation management visit would be coded at the high level of risk, even though you're sending the patient on to the hospital. And there are 3 elements here for the medical decision making, and to qualify for a level of MDM, you choose the row across that has 2 of the 3 elements met or exceeded. So straightforward, 99212, low 13, moderate 14, and high is 15. The same for the new patient categories, 99202 to 99205. And we can't forget about time. Because a lot of these visits are going to be more consultative in nature. When your counseling and coordination of care exceeds half of the face-to-face encounter, then it is going to be based on time. So make the time statement with the 3 bullets on this list. Note the total length of the encounter. It should be documented as a 35-minute visit. You don't have to go to the extent to say it was 2 o'clock to 2:35, but just a statement of 35 minutes is sufficient, with a statement that greater than half the time was spent in counseling and summarize what the counseling or coordination of care was about. Time is going to be very important for these remote visits. And now face-to-face time will be face time, not the time that it takes to review the chart or look at labs before the call is initiated, or make phone calls to follow up with other doctors, or phone in prescriptions after the visit ends, but actually the length of the FaceTime call. And this is in line with the 2021 changes that we're going to be learning about later this year in anticipation of January 1st, because we're going to be choosing the codes based on MDM or time, as long as an appropriate history and physical is documented. looking forward to that because it's been 25 years that we've been working under these rules that don't quite fit. So this is a snapshot of the new and established office visit codes that you will be using for these remote visits. The history exam, medical decision making. For the new patients, have to have all three of the components documented, so you can see how it would be very difficult to get a 99204 or 99205 using the exam component right now, and time on the right-hand column would be more helpful. On the bottom, however, you have a choice to figure out what would be the most advantageous to the provider. Looking at the two of the three components, you could have a detailed history and moderate medical decision making, and it only takes 15 minutes. Well, then code that based on the content of your SOAP note and not time. On the other hand, if you had a 25-minute visit and it was expanded problem focused history and low medical decision making, then time would be to your advantage for that one. So again, make sure you have a SOAP note and time, and then figure out which is better for you. CMS is not requiring additional or different modifiers associated with telehealth services that are furnished under these waivers. However, there are some scenarios where you are meeting all the criteria for this asynchronous store and forward technology. And if you are, you can still continue to use the GQ modifier. If you're doing telehealth services with a critical access hospital, then the GT modifier could be used. And with telehealth services for purposes of diagnosing an acute stroke, the GO modifier would be used. So if you're meeting all the regular rules, you certainly can continue to operate under them and report them. Other payers are asking for modifiers where CMS is not needing any on the remote evaluation management visits. So you might be asked to use either the GT or the GO modifier. And again, I would stress that you should check with the various payers for their requirements. They may be emailing you provider bulletins to your billing team. If they haven't, check on the provider portal to see if there's any instructions that you need to follow up so you can get your claims paid. State Medicaid programs also might have some variables in their reimbursement policies. The states were given broad flexibility to cover telehealth through Medicaid programs under these waivers. No federal approval is needed for the state to reimburse providers for telehealth services in the same manner or at the same rate that pays for face-to-face services. And a state plan amendment will be necessary to accommodate any revisions to payment methodologies to account for telehealth. So watch out for bulletins from MedCal or whoever your carriers are. The diagnosis coding is also important to get your claims paid. So as always, your E&M services should be in line with the severity of the diagnosis codes to report the symptoms or confirmed illnesses that the patient is having you address during this remote visit. When a patient comes in for chronic conditions and has this remote E&M, you know what the diagnosis codes are for those folks. But if they have a new ailment and you haven't been able to really give a definitive diagnosis, it is okay to use the diagnosis codes to report the signs and symptoms that are documented. The ICD-10 codes usually begin with the letter R. Under the statute, you do have flexibility without regard to diagnosis, so it doesn't have to be a COVID-19 related remote evaluation management visit. It can be for anything because the whole purpose of this is to prevent vulnerable beneficiaries from unnecessarily entering a healthcare facility when their needs can be met remotely. So this is all in the name of social distancing for whatever reason the patient needs to communicate with their provider. There is a new diagnosis code. It's not effective yet. It was just put out by the World Health Organization on January 30th. January 31st, they created the code U07.1 for test confirmed COVID-19. However, they're not taking that on claims until the effective date because it wouldn't be a valid ICD-10 code. They pushed up the effective date from October 1st to April 1st, 2020. But don't use it yet. It will be certainly here soon enough, just 5 more days. If the patient comes in and they need, I keep saying comes in, I'm sorry, but what I mean has a remote visit with you with audio and video, and their concern is because they traveled there is a status code Z71.84 along with any symptoms they might have. And a person who is worried and doesn't have a diagnosis, Z71.1 could be added, but try to use that in addition to codes for the signs and symptoms that they present with as well. So to recap, the effective date for all of these rules is March 6, 2020, and they will continue for the duration of the COVID-19 public health emergency. Medicare will make payments for Medicare telehealth services furnished in broader circumstances. These visits are considered the same as in-person visits and are paid at the same rate as regular in-person visits. Starting March 6th and for the duration of the COVID-19 public health emergency, Medicare will make payment for professional services furnished to beneficiaries in all areas of the country, not just HIPSA, and in all settings, home, not office or clinic. While patients must generally travel to or be located in certain types of originating sites, we don't need to worry about that at all. Starting March 6th and going forward, it's going to be in their home as well as any other location. Medicare coinsurance and deductibles would generally apply when claims are paid and you have a cost sharing or copay on your EOB. It is up to you whether you transfer that to the patient and collect it at a later date or waive it because it's difficult to operationalize collecting that copay. But we are trying to make sure that you don't take too big a hit more than necessary in your reimbursement. So if you want to collect these and you do accept credit cards over the phone or things like that, just let the patient know before they agree to a remote visit. That's going to be subject to copay, just as if they're coming into the office to see you. We don't want your patients upset. There are so many resources that are on the web. Yesterday, we found a great one with the AMA that is on the bottom here as well. They have a grid. So you can check these out as well as checking out your state medical association and your payers that you're contracted with. This is a very fluid situation. We've been asking questions, and then some of the payers and even CMS have been clarifying as we've gone down this road together since last Tuesday. I've been on the phone constantly with the MGMA's legal counsel in the Government Affairs Office in Washington, D.C., and I've been lucky enough to shoot them some coding questions that they bring right to CMS and get answers for us. So things are being clarified and things are being added to these rules as we go down this road together. Your handout will have an appendix of the rest of the telehealth codes that have not changed during this period of time, but for right now, I know that we have a lot to digest, and when we get over this together, you can certainly look at those codes. If telemedicine has been a positive experience for your practice and you intend to continue with it, then you can look at those and certainly reach out to me if you have any questions. So at this point, I will stop and ask Nicole if there are any questions in the queue.
There's a couple, and you might have answered these, but since they're more, some of them are kind of technical. I'm not a coder, and I don't work in an office, so I may just be repeating. But so the first one is we were under the impression that these telehealth services would be paid at the normal adjusted rate as a normal office visit. And that's not what we're seeing as claims are finalized. Can you expand on that?
If you're using the normal E&M codes 99211 to 99215, Medicare has said that they will pay them at the normal rate. If you're seeing differences in reimbursement, it may be that it's not a Medicare payer, and they might have different rules. And if you're contracted with that payer, then you're subject to the reimbursement policies. I'll give you an example. I believe in Massachusetts, Blue Cross is only allowing reimbursement for level 1, 2, and 3. So if you're billing a level 4, yes, you might see a dip in reimbursement because it's that payer's rule.
And from my understanding, the California Medical Association and the AMA has also written letters to all payers asking for them to pay at 100% of that rate. So I think at this point, it just depends on the payer. But watch out for my emails, and as the AMA gets this information through all of the payers, as well as the CMA, that may change. So just know that might be coming. The next question is do we know who pays for the 9941-3?
Typically, commercial carriers pay for that, but in California, you need to make some phone calls, have your billing folks talk to the payers that you contract with, and then come up with a grid of who will pay for it or not. It's not universal.
Okay, and then the next question is to confirm when we do a telehealth visit with the 99215 with the POS of 2, it has to be video and audio, or does it just the patient have to be initiated?
Great question, and we need to stress again, it has to be patient initiated, and both the patient and the provider have to be using both audio and video. Without visual, it's going to be billed as a telephone call.
So one of the questions that came up too is, so if another office is referring, this is a two-part question because it was asked 2 different ways. If a patient is being referred to another physician office, is that considered patient initiated? Is the first part. And then the second part was, where is it? All right, answer that one. I'll find the other one.
Okay. If the patient would be agreeing with their provider's recommendation to make an appointment with another provider, yes, that would be patient initiated.
If a doctor's call, patient and audio is the only way of communication, would this still be considered a G2012 for billing purposes?
Under the current time, the waivers will allow for telephone only for G2012, yes.
Okay. I believe a patient initiated means that oh, that's me, never mind. Are the G codes only for Medicare patients?
Yes.
Can you have a parent populate the abdominal while you watch it and document it?
No.
Pediatrician. You
No.
cannot. Okay.
I mean, because you wouldn't be able to feel what was in the belly, so no.
Okay. If a patient was already scheduled and we called the patient to go over labs, meds, etc., can this be a televisit billed a 99211 through a 99215?
Only if the patient requests it and there's audio and video and a SOAP note written down.
The second part to the question before, can you do telehealth? Can it only be existing patients, or they need a referral?
Right now, the codes will include 99201 through 99205 for new patients under the waiver. However, referral issues depend on the managed care payer and contract.
Okay. Can 99212-5 be used for commercial payers? If yes, when do we use 99441-3?
Yes, and you use the 99441-3 when there's telephone only. You use the E&M codes when there's audio and video. So it depends on the technology.
A patient is referred for a consultation from a PCP office. Staff schedules I think we answered that one already. Can we, oh, hold on. I would like to make sure that I understand that 1135 waiver. Can you please explain this?
The 1135 waiver is issued by Health and Human Services to provide for more access to health care remotely for patients to keep them at home during the COVID-19 emergency.
Okay. With respect to the post-op follow-up, I believe that the decision about whether to follow-up visit can be billed separately, face-to-face or telemed, will also depend on the FUD days included in the procedure/surgery code initially submitted.
Absolutely. If you have a visit that's bundled into a recent surgery, you can do it remotely, but just like in the office, you won't get paid separately because it's within the global.
I'm just scrolling. Everybody is very appreciative of the call. I am unclear why the e-visits through the patient portal is not the same as telehealth classification. The e-visit platform also has video and audio.
If you're using a platform that gives you audio and video and is patient initiated and is documented with a SOAP note, then you can bill the E&M codes using that platform. That's fine. The term that I use for e-visits is Medicare's description of G2061. That is specifically limited to portal communications.
Okay. Medicare payer is paying $52.97 in California for 99213. Do you know that?
No.
Is that correct? Graduate medical education is a large part of what we do. Do you know of any guidelines or requirements for residents or fellow physicians utilizing telehealth? And how would an attending physician document and bill? Ooh, that's a tough one.
Yeah, none of the guidance that was issued on March 17th from HHS Secretary Azar was specifically addressed towards physicians at teaching hospitals. So I would only make sure that you're following all of the rules as they would have to be followed for an in-person encounter. And if that is the case and it's documented and it's performed remotely with audio and video, then yes, go ahead and bill it.
Okay, and one more time, we will send these slides out to everybody at the end of the meeting. The next question is I suspect that CMS will be monitoring how healthcare community uses telemedicine during this period and potentially implementing findings into future CPT reimbursement policies. For example, if the majority of the post-biopsy, post-procedure, post-op follow-up visits can be adequately addressed by a non-face-to-face visit, it is likely that CMS will question why they should pay face-to-face visits when it's not justified.
Oh, that's an interesting thought. We'll see.
Yeah, it'll be interesting. Most of the Medicare patients can't do video conference, so virtual check-in is the only option. Any tips on getting Medicare patients to do a video?
Have their neighbor or grandchild come over with an iPhone?
Yeah, good, or their children.
Yeah.
How is the patient I know the patient needs to initiate the telehealth visit. Let's say the patient is calling to cancel their appointment. Can we offer them a telehealth visit? That's a good
Great question. And yes, absolutely. CMS and HHS have said it is encouraged for medical practices to make their patients aware of this option and keep them safe at home. So yes, please do that.
Do we have the capability for video at our office? So telephone encounter is the only option, but do we bill if codes 99441 through 43 won't get paid? Well, and let me jump in there and ask you kind of a two-part question. Is there any reason why they can't do this on their iPhone?
Right, they should.
Somebody in that office has an iPhone.
That's what came through my mind, Nicole, when they said our practice doesn't have video. I thought, wow, not one provider has an iPhone?
Mm-hmm.
Yeah, you can use the iPhone and you can use Skype on your computer and Zoom. So these things are free and easy to get up and running in 5 minutes. So, make every attempt to use video because the reimbursement for telephone only is too low.
Yeah, I agree. And we're working on another webinar that gives you implementing telehealth in your practice in different options. We just need to figure out how we're going to do that with what's out there right now because everybody wants to do it. If a patient emails a picture and the doctor looks at the picture and calls the patient, is that considered just a telephone call?
Yes, it's not live video.
Yeah. A post-op visit to discuss results, is that patient initiated?
It's probably going to be global and not billable anyway, but document that the patient requested. And if the patient would have otherwise had an appointment, did the office cancel the appointment and offer the patient the chance to reschedule it remotely? And then the patient said, yes, please do that. I mean, there's always a back and forth, just set it up. Just be mindful of the fact that the patient needs to be aware and agree ahead of time.
Can you please clarify what modifiers to use for telehealth?
Medicare is not requiring any modifiers right now for telehealth. Modifier 95 might be requested by commercial insurances or other payers to signify that it was provided remotely with audio and video communication platforms or devices.
How should a dermatology office use telehealth? That might be a bigger question that you may not be able to answer right now.
Yeah, I mean, they can use the E&M service codes as we've discussed. I mean, certainly a dermatologist can see a patient if they hold their arm up to the screen and show a mole. They can use it just the same as any other practice. There's no restrictions. Of course, you can't do any procedures. It's just the evaluation management services that you can provide.
Perfect. And then this is implemented now, so telehealth codes to Medicare is effective, correct?
March 6th was the effective date.
March 6th, okay. And this is the last question. We live in a rural area with little cell reception and terrible internet. Most of our elderly patients don't understand, want to learn video communication either. If we document this attempt to video, can we bill telehealth?
No.
No, I didn't think so.
No.
So, well, thank you, everybody. That's the end of our questions that came through. I appreciate everybody attending. I know it's everybody's super busy right now. Watch our emails that are coming out for additional webinars and additional resources for this topic. We send out, if AMA provides any new content to us, we send it out at the end of the day, along with updates from the California Medical Association on PPE. There's just a lot of content. And so if this is outside of Fresno, I'll start sharing my emails with the other medical societies if they want to send those out to you. But there's a lot of resources on California Medical Association's website, as well as emails being sent out by them as well. So thank you. And if anybody has any additional questions, please just feel free to email me directly.
Thank you.
Thank you.